Good evening, everyone, and welcome to the 24th edition of the 4D, which is the dialogues that we have in diabetes, specifically talking about diabetes in India. I think last week we covered some problems associated with diabetes care in India. We specifically covered the general problem that are associated with diabetes care. We looked at the barriers that come from the patient sides. We looked at the barriers that come from the health professionals. And we looked at some of the ways to address those barriers, including therapeutic strategies. We listened to how telemedicine helped us with overcoming some of the barriers. So today we have something very similar, but this is specifically looking at the treatment and the challenges that we face in treating type 2 diabetes. So not all diabetes care, but specifically type 2 diabetes. What are the challenges we face and what are the solutions that we can possibly have? And today, for that, we have with us Dr. Sunetra Mondal. Dr. Sunetra is, welcome, Dr. Sunetra. Dr. Sunetra is MBBS MD from Kolkata, DM in endocrinology from IPJEMR, Calcutta. And I think she's currently working in Durgapur, and she is, I think, one of the most brilliant endocrinologists from that side. We've seen some very good papers that Sunetra has written. So welcome, Sunetra. And I think the way we go about it, we will listen to your presentation first, and then we'll go into a Q&A for about, altogether for about 35 minutes. So over to you, Sunetra.
Thank you so much, Professor Jubin sir. And so I will start with my slide set. Can I please have the slides? So today we will be discussing about the challenges in management of type 2 diabetes in India particularly, and the possible solutions that we may have for these challenges. So it's not just a single challenge, they are manifold. If you're talking about the most important challenge, undoubtedly it is about the level of awareness, the level of patient education in our country about diabetes, about its risk factors, and more importantly about its long term complications, the effect on long term health and also mortality rates. And we many of us know that Indians possibly have a higher risk of complications, at least for macrovascular complications, than our Caucasian counterparts. And even then we are unaware, many of the patients are unaware about this increased risk. Quality healthcare is often not easily available, especially in the rural areas or the semi rural areas, and there are of course affordability issues. So it is essential to diagnose the disease early, intervene early, aggressively manage the hyperglycemia and its risk factors. And it is also mandatory to give an individualized management rather than something that fits all. So the first step would be to identify the barriers to quality diabetes management. So the barriers could be patient related barriers, of course, just as I said, lack of awareness. There is economic stress, there is denial of their risk, denial of having diabetes, denial of having other risk factors like hypertension, high cholesterol, and denial of having other complications as well. There is an overall emotional stress, psychosocial stress. Changing the behavior of patients often becomes very difficult. They think we are not eating anything, still we are having diabetes. And sustaining the behavioral changes are also very difficult. And this onus lies on the treating physician, of course. Then there are social barriers like levels of literacy in our country, poverty levels, patients belonging to different socioeconomic strata and different literacy levels again. This is a multilingual population, so somebody who is trained in West Bengal is not possibly going to deliver. It will be difficult for him to deliver care in a South Indian country in their language. And there are cultural barriers, there are religious and customs which differ from region to region. There are very sometimes very strange superstitions which hamper the lifestyle modification which is preferred for diabetes. There are strange beliefs again. There are which makes it difficult to just as I said, which makes it more important to individualize the care of patients with diabetes. And there are also barriers related to the medical profession itself. So the medical training is often focused more on acute care. Even nurses find acute illness treatment more rewarding. So they are not trained in the management of diabetes so much as they are trained in the management of an acutely ill patient. And also there is lack of trained paramedics, which further makes it difficult because most of the responsibilities therefore lies on the doctor himself. So we have challenges, but of course we have strategies. The first and most important strategy is, of course, to intervene early. So thankfully, diabetes has something which is like a warning, because before the diagnosis of diabetes, we have a stage known as pre-diabetes, in which the glucose levels, the HbA1c levels are borderline. And in this stage, if we intervene, if with proper education and with proper intervention, the patients can revert to normoglycemia or normal blood glucose levels. So the most important factor in the pre-diabetes stage is, of course, lifestyle management, obesity reduction for patients who are overweight or obese. Again, as we know, for the Asian Indians, the cutoffs to define overweight and obesity are different. So somebody may refer to a Caucasian or other guidelines and think that I am not obese, but as far as Indians are considered, that patient might be obese. So it is difficult to counsel him to lose weight. And therefore we the main focus is on lifestyle modification, of course, as far as weight loss or reversal of prediabetes to normoglycemia is concerned. But there are also other agents which are used. Metformin is commonly used in some patients. There are other agents which can help in weight loss. There are anti-obesity pharmacotherapies. Some of them are approved. And so with these approved agents, if we can lose a good amount of substantial amount of weight in obese patients in the pre-diabetes stage, it is possible. Even in the early stages of diabetes, as we know over the past few years, there can be a remission of their diabetes if we are intervening early, especially in obese patients. If they can lose a good amount of weight, which is possible mainly with lifestyle modification, and also to some extent with drugs, with medications, if we are using it in the appropriate patient. So talking about the therapeutic strategies, again, over the past few years, we have a number of very interesting molecules like the SGLT2 inhibitors and the GLP-1 receptor agonists, which have shown benefit not only with regards to glycemic reduction, but also so many pleiotropic benefits with regards to cardiovascular disease reduction, heart failure reduction, renal protection, and so much. So early initiation of such agents can provide a very good care to the patient, not only by reducing the glucose levels, but also taking care of their other risk factors and reducing the risk of long term complications. And it is important that for patients who are having a very high HbA1c in the beginning, which is very common in the Indian scenario, most of the patients do not come with an HbA1c of 6.6, 6.7. Taking the 6.5 is the cutoff for diagnosing diabetes. They will come with a HbA1c of 7.5, 8.5, 9, even more than 10. So it is important to target early, to start with a combination therapy, and where appropriate to start with an injectable therapy. And this combination therapy should include agents with different mechanisms of action and an acceptable safety profile. So if we are targeting early, we can reduce the glucotoxicity and we can reduce the risk for complications. So it is better to use metformin as the first line, because it is still the recommended first line for most patients. But we should preferably add on another agent which has other mechanisms and also other benefits in addition to glycemia reduction, like maybe an SGLT2 inhibitors. And of course, apart from the duty as a doctor to treat the patient, it's also our duty to educate the patient. That becomes sometimes more important than the medication itself. So patient education and patient empowerment. The patient should feel confident about his diabetes care. He should know when he should go visit the doctor. He should know how to manage his hypoglycemia. For patients who are receiving insulin, they should properly know what to do, how to take the insulin, what to do if there is an insulin side problem, what to do if some insulin is not available somewhere, what to do when they're traveling somewhere about the insulin. So these things the patient should be confident about when they're using insulin. And also telemedicine, as in the previous episodes also it has been discussed, that telemedicine has particularly become important in diabetes management. And this has this has become more important following the pandemic, because many of the patients could not reach their healthcare and they used to depend on telemedicine. So properly done telemedicine can actually help the patient to a large extent. Thank you so much, sir. Thank you so much, everybody, for listening.
So thank you, Dr. Sunetra. I think I got a lot of messages from there, but I'll focus on few things. I think first question that I'll ask you is, I asked the last expert we had in the last episode, he was from South India. I had asked him the same question: why is India considered the diabetes capital of India, of the world? And despite the fact, I'm sure you're working in Durgapur, you see a lot of poverty as well, and you see a lot of undernutrition. Despite all that, why is India the diabetes capital of the world? What is your opinion? We had a different answer from South India. Let's hear from East India.
It's a very interesting question. So I think there are many factors. As we know, it's all starts in utero, even before we are born. There are some hypotheses like the thrifty genotype, the thrifty phenotype hypothesis. So an undernourished mother, when she is giving birth to a small for gestational age baby, and when that baby is gaining weight, is achieving the catch up growth, often they become obese and they have an increased risk for obesity and also diabetes, often young onset diabetes. Secondly, as we know, since over the ages, India has more or less been a famine stricken and undernourished area, as we have been discussing. So our genes are basically programmed in such a way so as we can get over this, if in case there is any famine, we can get over undernutrition. So when thankfully over the past few decades we are no longer very poor, so we are getting to eat in abundance rather, and therefore these genes start behaving rather weird and they start making us obese and more prone to diabetes. Furthermore, we are talking about undernutrition, but it's not low in carbohydrates. Basically, we are taking more of carbohydrates and less of more important things like fibers. And with more and more urbanization, this thing has further increased. So we are taking very less fibers, very less micronutrients. We know many micronutrients are also important for insulin sensitivity and also insulin secretion. So we are taking only carbs and less of these things. So that is also an important factor why we are more prone to become to be having diabetes, type 2 diabetes.
Yes, so I think if I have to summarize, very similar to what we listened last week, it is not really undernutrition in terms of getting not enough calories. I think we are now having plenty of food. It is more of malnutrition, where most of our calories are coming from carbohydrates. We are getting less proteins, less micronutrients. And again, I think last week we had highlighted this point that maternal malnutrition is going to have an impact in terms of the babies who are born to mothers who are malnourished, let's say 20, 30 years back in Durgapur, who are malnourished, say 40 years back, and who were born 40 years back, would now have problems with metabolic problems like diabetes, obesity, and hypertension. So I think very similar answer we received last. So now, again, you talked about the barriers, the patient barriers. Patient, you said, may not want to get himself tested. That is patient barriers, but there also you talked about social barriers. Patient may be too poor to get himself tested, or patient may not find it or may not have the enough information that he needs to get tested. So question is, type 2 diabetes very specifically is a very insidious disease. You may have no symptoms for many, many years. Why is it necessary to diagnose type 2 diabetes as soon as somebody develops it, and as early as possible? And what do you think are the measures we can do to try and make sure at least those who are at high risk are screened for diabetes?
Yes, sir. So we have several landmark trials which have actually showed something known as the legacy effect. That if we are having very high blood glucose for some time, even in the and we can control it early, even in the long run, there is a reduced risk for microvascular complications and to some extent also macrovascular complications. So we know that it is important to intervene early to prevent the long-term microvascular as well as to some extent, as I said, macrovascular complications, and also preserve our beta cells as much as possible, because more and more glucotoxicity would damage the residual beta cells that we are having. And if you are not intervening early, if you are leaving them to the exposure of high glucose levels, the residual amount of beta cells that are there would get damaged. And the high glucose levels, there are many mechanisms by which they can go on to damage our blood vessels, our nerves, our retina, our kidney, and so on. So it's important to intervene early. And for this, we know who all are at high risk. So talking about South Asians, I guess almost all of us, all of the adults are at high risk, and our BMI cutoffs are different. So anybody who is overweight or obese, anybody above the cutoff of 22.9 kg per meter square, and belonging to South Asian, and of course, if they're having additional risk factors like hypertension, like a family history of somebody with type 2 diabetes, like a mother who has had a history of gestational diabetes in the past, or other high cholesterol levels, some other risk factors as well. So all of them must be screened at least once in a year. They should test themselves for whether they are having diabetes or even pre-diabetes.
So I think the point here is, one, whenever they come to a hospital, if they are over a certain age and they have not been tested for diabetes, they should be tested. And also you may need to increase awareness that people are not coming to the hospital also need to get tested. Something very interesting that you said in your presentation is that as South Asians, we have a different cutoff for obesity and what is overweight. We want to clarify that for our listeners. What is the South Asian cutoffs for calling somebody overweight or calling somebody obese?
So as we know, BMI, body mass index, is calculated from our weight in kgs and height in centimeters, height in meters. And so if we look at the South Asian cutoffs, anything between 18.5 to 22.9 is considered normal. Less than 18.5 is underweight. 22.5 to 25 is overweight, and anything beyond 25 is obese. So this is the cutoff for South Asians.
All right. So thank you for making that clear. So I think we do not really need to use the Western cutoffs to decide on screening diabetes. Anyone with a BMI which is in the overweight category or which is in the obese category definitely needs to be screened for diabetes. Now, one of the problems with screening, or I don't know whether I call it problems, or one of the good things about screening, is you will find people who do not meet the criteria for diabetes who are still not normal. And if you look at surveys in various parts of India, almost if you find one patient with diabetes, you will find two patients with something what we call pre-diabetes. That means they have slightly higher fasting glucose, or slightly higher postprandial glucose, or slightly high glucose if they're doing an oral glucose tolerance test after 2 hours of. So what exactly is pre-diabetes? I know you covered some of it, and you also covered that why is it important to address this group of patients, and what can we do for them?
Yes, sir. So just as I said, that diabetes thankfully has a warning period, which is a period of borderline high, borderline deranged blood glucose levels. So a fasting glucose between 100 to 125, a post glucose challenge PPBG of post meal glucose, post glucose challenge glucose of 140 to 199, and an HbA1c between 5.7 to 6.5%. So anybody with any of these would qualify as somebody with borderline high glucose, or something known as we call as pre-diabetes. So this is the period when we should intervene, because from this phase a patient can go on to develop diabetes. Many of them will actually, and rarely, not rarely actually, if they can take good care of their health, if they can lose a good amount of weight, and sometimes if we give them some medication, they can actually revert back to normal. So lifestyle modification is very, very important in the pre-diabetes stage, because with proper lifestyle modification and proper intervention, many of those with pre-diabetes can become normal. And those who don't, they have to check their blood glucose levels more frequently to know whether they are going on to develop diabetes. And also, as we know, the complications of type 2 diabetes not only start from the diagnosis of type 2 diabetes itself. Sometimes some of them can start as early as in the pre-diabetes stage. So possibly it may be necessary to screen them for these complications and comorbidities as well when their pre-diabetes are not getting reverted to normal.
All right. So you told us that pre-diabetes is one place where you can intervene. You can prevent progression to diabetes. Also, you can intervene in terms of other risk factors like cholesterol, hypertension, and prevent long-term complication that may happen with pre-diabetes as well. And you told us that the best strategy is lifestyle modification, which includes changing diet, exercise, sleeping 8 hours a day, reducing stress, and many, many things that stopping smoking, consuming alcohol in moderation. So many things are part of that broad term lifestyle modification. Now, in people are interested to know whether drugs help or not. And do you think there are drugs which are helpful in patients with pre-diabetes to help them or to help them lose weight or to prevent them from developing diabetes?
Yes, sir. So, from certain trials, we know the medication that has been mostly studied in pre-diabetes stage is metformin. And again, if we go by the guidelines, it is not for all. It can be given at certain BMI cutoffs, certain age cutoffs. It is not for all. But for the very obese patients, if we give them anti-obesity pharmacotherapy, which are approved for obesity management, like Orlistat, like GLP-1 receptor agonists, and some people may need bariatric surgery as well. Those who are morbidly obese or obesity with one or two other risk factors, they may undergo bariatric surgery to undergo a good amount of percentage of current body weight loss. And so, a body weight loss of 10 to 15% of their current body weight may actually revert back to normoglycemia from their pre-diabetes stage.
All right. So now I'm going to ask you a question which is probably out of the syllabus. Do you think there is any role for SGLT2 inhibitors and some of the newer drugs that we have in addressing? Because we know SGLT2 inhibitors help in cardiovascular disease, in heart failure, even in those who do not have diabetes. It helps in renal disease, even in those who do not have diabetes. Do you think potentially there could be a role in pre-diabetes in preventing the long-term complications of diabetes and also preventing conversion, and if it helps with weight gain, to help you with remission of diabetes?
So I do believe it is potentially a very good agent, because it can cause a very good amount of weight loss. It can take care of the other risk factors that come associated in the pre-diabetes stage, like high blood pressure levels. uh, as we know, over the past few years, there have been trials in non-diabetics as well, of SGLT2 inhibitors, and it has shown benefit with regards to heart failure and renal protection, even in non-diabetics. And of course, in pre-diabetes, if you're using it, can prevent the long-term complications that come associated with it or with diabetes, as well as take care of the other risk factors. And most importantly, it will cause a good amount of weight loss. So of course, it is going to be a very promising agent in pre-diabetes.
So I think we will stop discussing pre-diabetes, go to diabetes itself. Our challenge was to discuss about type 2 diabetes. So here I'm going to ask you the most important question. Now, use two words. One you used was individualization of care. That means each patient you come, you decide on therapeutic treatment based on his particular the particular individual. The second word that you used was, we do, one of the barriers from physicians is we do have a lot of physicians who are not trained. You are very well trained. You've done your MD, you've done your DM, you're an expert, but diabetes is such a huge disease. I'm sure majority of diabetes is treated by patients or by doctors who do not have your qualification or your expertise. So to them, I'm going to ask you a simple question. How do you decide what drugs to use? When do you decide to use a combination drug? Does what the patient consume, let's say he consumes a lot of carbohydrates, or he's not able to keep control on his diet, does that impact how you choose the drugs? So just a very simple guideline to people who are listening and who may not be as well trained as you, about how will you choose these drugs. And you said early use of combination. How will you go about doing that?
So metformin is lifestyle after lifestyle modification. Metformin is still now the first line drug which I use for almost all my patients, except those who are truly metformin intolerant, and those who have other contraindications to metformin use, maybe a stage 4 CKD or a decompensated chronic liver disease. Otherwise, metformin is still the first line that I use. If I use a combination therapy in patients who have a high HbA1c, say around around more than 7.5 HbA1c, if they're having, I start with a combination therapy. Now, the second medication that I use over metformin is decided based on the patient's risk factors. So if they are having an underlying established atherosclerotic cardiovascular disease, or they are having multiple risk factors for an atherosclerotic cardiovascular disease like hypertension, high cholesterol levels, etc., I prefer adding an SGLT2 inhibitor to the metformin. If the patient is not having any of these risk factors, even then, if they're obese, I still add one SGLT2 inhibitors. If they're not having either obesity nor any of these risk factors, and they're, as you said about their diet, so if they are taking a very high carb diet, so as we know, there have been some studies which have shown that the incretins in Indians, it's a bit different from our Caucasians, and in Indians maybe the gliptins actually work better. So I prefer adding one gliptin or one alpha glucosidase inhibitors if they are taking too much of carbohydrates and if they can tolerate it. And sulfonylureas I use rarely nowadays. If the patient has already been taking, I do not discontinue it. But if they are having very high glucose and not very reluctant to take insulin, in some of these patients I do add one sulfonylureas as well.
So if I have
And
to
for
summarize,
anybody more than 10, I start injectables.
so if I have to summarize, anybody who comes to you with diabetes, definitely you're going to start metformin. But if their HbA1c is more than 7.5, you're definitely going to start two drugs. One of them will be metformin. If the patient is obese, has risk factors for cardiovascular disease, or already has cardiovascular disease, or has renal disease, as proteinuria, you would prefer to use a combination of metformin and SGLT2 inhibitor. Now, if they don't have any of this and the patient consumes too much carbohydrates in his meal, you would prefer DPP4 inhibitor. And I think both these drugs are now available as generic preparation in our country. So we do not need to really worry about the cost like we used to worry about it, let's say 2 or 3 years back, where both SGLT2 inhibitors and most DPP4, the good DPP4 inhibitors, were expensive. Now, most of even the best DPP4 inhibitors are now available as generic preparations at fairly reasonable prices, I think. So I think, and again, when you said HbA1c more than 10, you would prefer to start insulin along with these drugs. And so I think that's fairly a straightforward message coming from you. So vast majority of patients, it would be SGLT2 inhibitors with metformin if the HbA1c is more than 7.5, and our obesity cutoffs, the people you will call obese, are based on Indian cutoffs, not based on the WHO cutoffs. So most of us will end up being either overweight, or most of our patients will end up being either overweight or slightly obese. Next question that I have is, when we treat diabetes, we are treating diabetes not just to control the sugars, but to prevent long-term complications. So I think, do you think as physicians, we give less importance to that and pay too much importance to glucose control, and the patients also don't pay enough attention to the long-term cardiorenal risk reduction that is very important? And now even liver risk reduction is considered to be important, along with the standard traditional microvascular risk reduction. So what is your opinion on this?
Yes, so yeah, however much we may try to counsel the patients regarding the need for routine screening of these complications, at least one annual creatinine and urine albumin creatinine ratio, one annual lipid profile, one annual LFT, liver function tests. Most of the patients will not come up with this. They will just come up with their fasting PP, sometimes not even their HbA1c levels. So cost is a concern, definitely, but still it's our duty to explain to them how important it is to screen. Because if we are only taking care of the glycemic part, it's not going to help them. They will definitely be having one or the other risk factors. It is extremely rare for a patient with diabetes not to be having dyslipidemia. Dyslipidemia, as in their LDL, the cutoffs that we prefer for diabetes, most of them will be having LDL cutoffs above that. So is very important, and it's our duty to emphasize the importance of the screening tests to the patient, including of course NAFLD. So this fact is not even endorsed by many of the physicians nowadays, the importance of NAFLD. Some of them will go on to develop steatohepatitis, and amongst them some of them will go on to develop cirrhosis and end-stage liver disease. So it's important to screen them early.
All right. So, last few questions. How now? Do you think that despite the fact you said that we have complications early, primarily macrovascular complications, we seem to have a decade or decade and a half earlier than Caucasians. We develop diabetes also about a decade earlier than Caucasians. We develop macrovascular complications about a decade and a half earlier than Caucasians. Despite this, that young patients are developing these macrovascular complications like MIs and strokes, do you think that the number of patients who come to your clinic, what is the level of awareness that diabetes can lead to these complications, and they lead to these complications in a much younger age in Indians?
So actually, the hospital that I work in is predominantly a cardiology hospital. So most of them will already be having an established cardiovascular disease. But if I talk about outside the hospital, again, the level of awareness is very poor. That is the reason they are coming with a heart attack at first, then getting diagnosed with diabetes. So it's the level of awareness is still very poor, and it's the duties again on us to improve the awareness. Maybe we should do more of patient level programs, more of awareness campaigns. This message should be discussed in the news channels as well, time and again, the importance of screening for diabetes as well as its comorbidities, to improve the awareness of the patients. And it's also necessary to train the paramedics, the nurses, to lead the patient to the doctor, to get them screened in time.
All right. So I think the next question I have is, when you treat diabetes, you always treat to a target. You in your mind, you have a target, and generally we'd say that the target is, let's say, less than 7 or as close to normal as possible. If you can get it to 6.5, do you have the same way that you decide on your drugs based on the patient in front of you by individualizing it? Do you individualize your glucose targets as well in your clinic based on the
Yes,
patient in
of
front of
course.
you?
Yes, sir. So, yes, so diabetes cannot be a one size fits all. The HbA1c target must be individualized. So, for somebody who is 80 years old, and somebody who is 40 years old, somebody who is having other risk factors, like other risk factors that shorten their life, maybe like an established chronic kidney disease and established end stage heart disease or something, the target HbA1c need not be that stringent as we would want for a young guy with no other risk factors, because he is going to live another 40 years. So the need to reduce this long term complications is much more important in a 40-year-old than a patient who is elderly and with many other comorbidities. Additionally, if we are too stringent about the target in the second group of patients, there will always be an increased risk for hypoglycemia, which is also a very important area of concern and an important cause of mortality and morbidity as well. So we cannot take the risk of causing hypoglycemia. Even with the newer agents, there still is a smaller risk, is a small risk of hypoglycemia. And so individualization is definitely very important. And
All right.
again,
So
there
I think
are other things cost. Has been some discussion about ethnicity specific HbA1c target also, whether we should be having. So yes, a large number of factors I take into account while deciding on the HbA1c of target.
so. Thank you, Dr. Sunitra. I think we have come to the end of it. I have one last question. Did you take care of COVID patients during the peak of COVID, in addition to looking after your patients with diabetes?
Yes, once or twice I had to do
So
duty in COVID.
again, so I'm going to ask you this question: how did that pandemic impact your diabetes care? Were you, like, when you were involved in taking care of patients with COVID, were your patients with diabetes being neglected, or how did that impact diabetes care in your practice?
So diabetes I had shifted a lot to telemedicine during that period, and many patients actually found it quite comfortable, but not all of them. And also the pandemic, during the pandemic, the patients had such a sedentary lifestyle, and they were eating a lot, they were not exercising. And of course, the COVID itself had very detrimental effects on the beta cells and on insulin resistance as well. So many patients were having new onset diabetes and worsening of their glycemic status after they had COVID or after they took steroids for COVID-19. And so yes, it had a lot of impact on the patients. And just like diabetes had a legacy effect, some patients actually had a legacy effect of the pandemic. So lockdown was for a few months, but they turned off after 1.5 years and told it was lockdown. So I came late with an HbA1c of 9. So it, yes, it was, there were a lot of bad effects of the pandemic.
So thank you, Dr. Sunetra. I think we've exceeded our time. I think if I have to summarize what you have very clearly said, the primary challenge in type 2 diabetes is diagnosing them early. And if we diagnose what we call as pre-diabetes, which is a precursor to type 2 diabetes, lifestyle remains the primary focus for these patients to prevent development of diabetes, also to prevent long-term complications. And possibility is there among these patients to completely reverse this glucose intolerance, the pre-diabetes that they have, if they lose weight. So we don't call it reversal, we call it remission of diabetes. We don't use the term reversal. And in addition to lifestyle, sometimes you prescribe drugs to help patients prevent diabetes or have remission in diabetes. Once patient develops diabetes, you are very specific in addition to lifestyle, you would all start them on metformin. If their HbA1c is more than 7.5, you would probably use a combination, which is metformin plus SGLT2 or metformin or DPP4, depending on the individual patient in front of you. If the patient is obese, has hypertension, has dyslipidemia, has cardiovascular disease, has a renal impairment, you would prefer to use metformin and SGLT2 inhibitor. If patient has none of these and also consumes a lot of carbohydrates, you would prefer to use a DPP4 inhibitor. And all these drugs are now available as fairly cheap generic molecules. I think almost lots of brands are available of both these DPP4 and SGLT2 inhibitors. And I think what you are attempting to do is not bring down HbA1c to 6.5 in everyone. You have an individualized target. But regardless of glucose control, you are primarily interested in preventing long-term complications. So you would use drugs that help prevent the cardiorenal complications. So thank you, Dr. Mandal. Any last words you have before we say goodbye?
Yes, so just as I said, it's important to intervene early and preferably in the pre-diabetes stage. And diabetes, if well controlled, you are going to have a very healthy life otherwise.
So thank you very much, and we'll hand it back to the organizer.